So good afternoon, everyone. Thank you for joining us for today's Teach Educational Rounds. Today's session is Complex Client Journey Part 1 with Rosa Dragonetti and Alexandra Andric, who will be facilitating today's session. And we will be having a Part 2 series, which I will be discussing later this afternoon in the hour, just about what that will look like as well. If you're interested in obtaining a letter of completion for today's webinar, just remember you do need to register for the webinar and complete the pre-learning assessment. Make sure that you are signed in with your first and last name, and you do need to attend for the full hour in order to be eligible for that letter, and also to complete the evaluation and post-learning assessment, which I will be sending out following today's session. These webinars are being live tweeted. Follow us at CAMH Nicotine Dependence Service on Twitter at PSQuitSmoking. And to follow the live tweet or to post your questions or comments using Twitter, follow #TeachWebinar.
Perzai, can I interrupt you for a sec?
Yep.
And because today is Bell Let's Talk Day, maybe add the #Bell Let's Talk so we can raise awareness and funds for the mental illness.
Wonderful. Thank you for adding that, Rosa. So our presenters today, Rosa Dragonetti. Rosa Dragonetti is the Project Director of Addictions Research and Education at CAMH. I'll let you read those yourself. Alexandra Andric is a registered nurse who has worked at CAMH since 2006 and is actually at the Nicotine Dependence Clinic as well, providing counseling support. These are our disclosures. Our faculty disclosures, none to report. The Teach curriculum development slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Content of the slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussion, set out only general principles and approaches and do not replace the need for individualized care. So as mentioned, this webinar is following a two-part series, and it will consist of a case presentation and summary. So we had, during the registration, asked a number of you if you had a complex client case that you would like to present. So we have taken one of these cases, and we will be presenting on that today. So that will be about 5 minutes, followed by participant discussion about the case, then recommendations by our facilitators, and then we'll wrap up with final thoughts and questions. So before we get started, we're going to do a few polling questions. So please indicate what type of organization you work for. And you can do so just by clicking on one of the options. If your option is not included, please type that into the chat box. Great. So it looks like we have a number of people from public health units and hospitals, and family health teams. Okay. Our next polling question. Oops. Please let us know what your discipline is. You may have to scroll down just to see all of them. So a lot of registered nurses. Okay. And our last poll. Let us know what let us know what region your organization serves. And again, if you work outside of Ontario, if you can let us know in the chat box. Great. So it looks like an even split between the GTA and Southwest. Okay, thank you, everyone. So today's learning objectives, we're going to develop a treatment plan for a complex case in tobacco cessation and identify best practices in tobacco cessation treatment across all stages of the client's cessation journey. Now, I'm just going to ask if Joanne Douglas is on the line. If you are, can you please unmute your line?
Yeah, I'm here.
Hi, Joanne. Welcome. And is Bridget with you today?
Yes, she is.
Okay. Is there anyone else with you?
No, just the two of us today.
Okay, great. So I'm going to let you get started with the case presentation, and if you want to just also let us know what your disciplines are so we have an idea of who is involved with the treatment of this client.
Okay. So good morning. It's still morning in Manitoba. Can everyone hear me all right? Okay, I'm going to go ahead. You can chat in the little box if you can't hear me. We work in Brandon Regional Health Center, which is in Brandon, Manitoba, a large hospital, referral center, and we're part of an ambulatory clinic. So we see many patients. We have lots of disciplines within our clinic. So I'm a tobacco dependence counselor, and Bridget is a registered nurse and is our lung health clinic nurse. So our client, who we would like to get some help with, first presented to our clinic because she had COPD and the normal terrible cough that goes with that. So she was in our pulmonary rehab program. She's a 69-year-old woman, a widow. On my report, I said she was a psych nurse. It turns out she was a healthcare aide who worked in a nursing home in a nearby small town. She was found to be severely underweight and not eating, so she then saw our dietitian, and then she saw me because of the smoking. And then she also ended up seeing the psychologist because of a lot of family dysfunction that we weren't qualified to deal with. She smokes, I'd say usually a pack a day, but she has sometimes dropped down to 10 to 12 cigarettes a day, but never for very long. It usually goes back up to the pack. She's full of excuses. She's averse to all quit smoking medications and lists the strange side effects that I haven't usually heard before, so she seems to be completely opposed to using anything. The dietitian is trying to work with her weight. She needs to gain 30 to 40 pounds, so she's quite underweight. She does tend to smoke and drink coffee and not eat, so that's an issue. The family's a little dysfunctional. She lives in the basement of her daughter's home, and the daughter tends to make our patients stay downstairs because of her smoking. Even though the daughter herself is a smoker, she doesn't want her mom's smoke upstairs. The daughter has started to cook a few meals for her mom and sends a grandson down to feed her, to give her a plate of food. So it sort of disturbs us that it seems like she's kept in the basement and they throw food to her a few times a day. We asked about going upstairs to eat with the family, but it sounds like they don't actually eat at the supper table as a family. She has a lot of excuses for everything and admits that she has a pity party going on. The daughter won't take time off work to attend an appointment with her, so we have trouble trying to find out that side of the story, what's going on with the daughter, who is a grown woman with 2 children. I've tried to work with her using the 5 R's because she's so resistant, but she does seem to agree with everything, so it doesn't seem to be working. We've also tried baby steps where we say, can you reduce by just 2 cigarettes this week or this time, and she returns smoking more than ever. And when we ask her what happened, her usual response to a lot of things is, I don't know, you tell me. So she doesn't have a lot of answers for stuff. What else can we say? She's got, now she seems to have developed osteoporosis, which she's very worried about. She's lacking energy and can't cook, although we don't think she has anorexia or bulimia. She does seem to like food, and is pleased when her daughter sends food down, but she's too tired to cook her own meals. Oh, and she has some swallowing issues, although they were kind of mild when the swallowing assessment was done. We think she has financial issues, although we're not really clear about that. So she'll have excuses like she can't even buy a notebook to journal, or she can't go out to a social activity because she has no money, but she does pay for her grandson's private school. So we're not really sure, is she as financially in dire straits as she says she is. A positive is that she loves her grandson, and they have a good, close relationship, and she worries about him inhaling the secondhand smoke because he's the one that comes down to her area of the house. Another positive is that she continually shows up for appointments. She's never missed, and I think you all know how sometimes if you have a non-compliant patient, they don't show up again, but she faithfully comes to the appointments, and in fact, we wonder if she just wants attention because she really overstays, and we have to kind of get up and say, okay, time for you to leave, because she wants to talk and go off on tangents, not really addressing her own issues, but other stories. So we've tried all kinds of things. I've tried to make her come up with the suggestions rather than me tell her what to do, but she just says she doesn't know and she has an excuse. I'm just going to tell you one example of an excuse. We were talking about trying to do 5 little things first before she reaches for that cigarette, and she won't get the cigarettes out of the house, so she does keep them accessible at all times, which isn't very helpful. But I asked her if she could just grab a couple of soup cans and do 10 arm lifts, for an example of something to, a strategy to stop from smoking, and her answer was, no, her hands cramp up if she has to hold soup cans. So it's like everything you think of, she has a way to get out of it and can't think of maybe an alternative. And our psychologist is working with her as well, and so the same things, trying to get her to look for some change, think more positively or realistic, because she has a lot of negative thoughts, spends a lot of time in her basement alone thinking about, dark, dreadful feelings. Things like, oh, I'm a burden on my daughter, and which we really don't think that there's any realistic aspect to this. This is her thoughts. So that's about it. Unless, Bridget, do you have anything else to add?
She just has she has lots of responsibilities too with her family. She runs her grandson to school every day, and she has a lot of responsibilities that I'm not sure how she performs them based on when she comes in here with her shortness of breath and her and the way she manages or can't cook for herself, etc. But her family is reliant on her for a lot of things too.
I'm looking at a couple of the chats, and yes, she needs social connections, and there are a couple of seniors groups in town, but she will make an excuse that she can't get there, which we don't understand because she has a car and drives the grandson to school. And sometimes they charge a minimal fee to attend a program, and she says she can't afford that.
And she used to be part of a religious support group, but she didn't believe their values.
Oh, and then she did belong to a religious support group, but didn't believe their values, so she quit that. She claims she can't phone friends because it's long distance. All her friends live out of town. We did finally push her to find out she has a phone plan, so she actually can phone friends. So a lot of the things are...
and I offered her a mental health support group for elders, and she didn't accept that either. Yeah.
So she's kind of resistant to any helpful suggestions or in coming up with her own ones. Somebody asked if she's been a widow. I think we're not even sure. That seems to be no mention of the husband, so we think that he might be long gone or...
Yeah, she was a single parent.
Yeah, and she was a single parent of the daughter who's in her late 30s. So does that sound like enough to get things going?
I think that's a lot, so, and I'm sure there are other layers, but maybe we could just start, and I've seen that people are already putting in lots of really great comments, which we're going to look at in a couple of minutes. But first of all, just some general questions. Maybe we can start off with, what are some of the obstacles that the client is facing? What are some of the challenges that you think are involved with this client? So if you want to start with typing those in. because she certainly has a lot. It's, again, this client is what we would say very typical in our clinic. We see a lot of clients with multiple challenges, multiple issues, and the solutions are also as complex. Okay, so people are starting to put in, so she's an undiagnosed mental disorder. Yes, there was mention of the possible depression and anxiety. Let's see, undiagnosed clinically depression. She isn't really ready to make a change. The conviction is not there. Sense of control. So there is a control issue, right? There's somebody earlier on in the things had putting elderly parents in a basement is abusive. So lots of reaction to that. So she has kind of lost some control. Living in a home with other smokers. Possible barrier is her experience as a psychiatric nurse. So she's not a nurse. We got some clarification, but she did work in the field, and so you know, those experiences are going to have an impact on her for sure.
Lonely, that's probably a huge factor. Maybe she feels that the cigarette is the only comfort in her life. Besides, I mean, her grandson is a big factor for her because it's interesting. She has the energy to take him to school and as you both mentioned, Joanne and Bridget, she has a lot of responsibilities that she does complete for the family. And so I'm thinking she's going to have hardly any energy with the COPD. Then you add the depression on top of that, or we can say for sure a lot of sadness. That might take everything out of her, and maybe that's another thing to add to the complex pie here.
Absolutely. So I think that people have pretty much commented on most of the things that we also identified. Just a couple of extra things. So definitely her weight. I mean, yeah, her weight is a problem. The fatigue because of COPD or the weight or other issues.
Smoking even.
Yeah.
And if I think about both of you had shared how she has coffee and cigarettes, that's her fuel. So I feel like how will she be able to think or engage in activity when there's nothing, like it's all stimulant based, and then she's going to come crashing down again as well.
Yeah, absolutely. Okay. So definitely using a screener such as a PHQ-9 to better assess, to actually see if it's just some severe not just severe sadness, but sadness, or do we have a clinical depression here that requires some treatment. Fear is a big one as well. Thanks, Shauna. I think that's really important to identify. Just lost our screen there. I don't have, the other thing is one of the obstacles, and now we're kind of moving into what are the obstacles for the healthcare providers or the treatment team in this case. She won't take her medications because of some odd side effects, which I would love to hear more about. Anything else?
And I'm even thinking like how you guys have really tried your best with the 5 R's. So you are really trying to be using your motivational interviewing techniques. It sounds like you're using your spirit, because if that person would not come back and see you or all the people that she's seeing as clinicians if she didn't have that rapport. And when you have that rapport, that can kind of help you, at least maybe have that person talk about things. So I think, when I think about this case, this person's very, very ambivalent. And I think, for us as healthcare providers, how do you sit in a room week in, week out, where, it's the same old? And I mean, at least she's coming there. So there's a part of her that does want to do something, but it is very hard. So what kind of strategies as a clinician can you use to stay in the game and not get discouraged about it, and then also feel like you're doing something as well? So I think, for me, that kind of screamed out to me as a clinician in this case.
Yeah, I agree. And earlier on, I saw a comment which was the first thing that popped into my head as Joanna was presenting the case, is that it looks like the treatment team is trying really, really hard, And to me, that's always a sign, that's one of the signs of ambivalence. If we're doing more work and we're really struggling to come up with the strategies and the solutions, and the client is just kind of knocking down everything we say, that screams ambivalence, because we should not be the ones working this hard. But kudos to you for the effort that you've been making. And I think there's other things, right, so I think we can all agree she is quite ambivalent. You know, you've used terms like resistance, making excuses, you know, refusing to try certain things, saying that's not going to work. Those are all clear signs of ambivalence. So that's, I think, where we need to start, because, you know, I was curious to hear about the CBT, which, you know, that's something that we practice here, and that's the treatment of choice, but it's the treatment of choice for somebody who's ready. And so one of the things that struck me in looking at this case is, are we giving her too much because she isn't ready, and really taking a step back.
And then if I could, I mean, we're kind of jumping a bit here and there, but I kind of wanted to highlight someone, and I apologize, I can't remember the person who said it, the agenda setting or mapping. She could be very helpful, because that gives the client a chance to pick what they want to talk about, and maybe focus on that during the session, because we need that buy-in. And as I say that, I think about how you guys had shared that she does journal, but nothing comes out of it. So, you know, even asking that question, you know, I'm a bit struck by, you know, how things are going right now, just wanting to make sure that, you know, we are being helpful to you. You know, what do you need to get to where you want to be, or where you want to be? And another interesting part too is how the daughter smokes. So I'm thinking the daughter must smoke outside. Is there? I'm guessing there, but I'm wondering if she would, even, because the love of her grandson is a big thing. So to create discrepancy there about, you know, your grandson's really important to you, and you don't want to smoke around him. We're not saying for you to stop, but could you just take it outside?
Yes, the daughter smokes on a balcony, in past had crack addiction. The daughter, right? The daughter had crack addiction, and she does smoke on a balcony. So, so that, maybe we can talk a little bit about that relationship.
Yeah.
Because, you know, part of me says, you know, what are the strengths that this client is bringing? One of them is that she's living with family. But as we talk more and more about this case, I don't know that that's a strength. I think that's an additional obstacle. And it feels, Joanne and Bridget, you might correct me if I'm wrong, the sense I'm getting is that there's a lot of judgment coming from the daughter. It feels like the daughter is angry with her and punishing her for something, because it's true, to put somebody in a basement and not allow them to come up because of a behavior that you're also engaging in kind of just seems a bit odd to me. So I'd love to know a little bit more about that relationship. The other thing is, she sends her son downstairs to bring her food, so the mom doesn't seem to be too concerned about sending her son into a smoke-filled room or an environment, but doesn't want her mom upstairs. So I think the smoking is an excuse on the daughter's part. There must be something else going on. So let's see. Yes, the daughter smokes on the balcony. Yes, I agree. We wish we could see the daughter. Yeah, and somebody had made that comment about this, you know, it's almost like treating the client individually is such a small piece of it. If you could treat the whole family, because there's some dynamics going on here that are clearly coming in the way of this client being able to make any changes. So in terms of recommending the treatment plan, let's just go back a little bit. So I think we all agree that the client is ambivalent. But is she completely ambivalent? Are there any signs, and I guess this speaks to some of her strengths, that show you that there is, well, I guess this is part of ambivalence. What do we see here that shows that the client does want to make some changes? Because there are a couple of things that kind of stood out for us. Yeah, she keeps coming back. Thanks, Tammy. Absolutely. So you know, she may be ambivalent, but she comes to all her appointments, and she's seeing several healthcare providers. Like, think of all the issues she has, and all those appointments that she must have, how overwhelming that is, and yet she keeps coming.
Mm-hmm.
And she journals, right? So she has had spells where she reduced.
So does she know, like, what is different about those days where she is able to reduce? Is she aware of that? Like, what is different when she smokes less? What is different about that day?
Interesting. Oh, yeah, so Kim presents a good point. Coming to appointments does not necessarily indicate readiness. It could represent another need being filled. So how would you assess that? What do you do with that? That's a really good point. What would let's hear from them first, because I know what you're going to say. So some really good suggestions coming along here.
And Gary talking about, are there any other substances besides the tobacco going on too? Yeah. And we know that she does drink lots of coffee. I don't know how much though.
It looks loads of coffee. So yeah. You know, when you hear clients, I have anxiety, and you're smoking and you're drinking a lot of coffee, you have to wonder how much of that is the stimulant effect, right? Mm-hmm. But what about in terms of going back to that comment about coming to an appointment doesn't necessarily indicate readiness or an interest in quitting, that there might be some other reasons for her to be coming to the appointment. What would you do with that? How do you kind of tease that out a little bit?
And while people are typing, I just wanted to let people know that there was a question about whether Zyban would be appropriate for this individual, and I just wanted to say that because she's very underweight, we don't know if her electrolytes may be out of balance, and that's probably why the physician may not want to prescribe because of that seizure risk. And also, which I just learned today, that bupropion XL is actually off-label use to help with obesity. And we know here that oftentimes when people are worried about weight gain, when they use bupropion, they don't gain weight for the time that they're taking the medication. So that could be another reason why that physician was not comfortable prescribing the bupropion. And then I'm also thinking about the meds, which I know you had put down some of the things she had stated, but maybe using that EPE intervention to maybe try to provide some information for the client and see if that may make her, I don't want to say make her, I want to say maybe that might be food for thought. Mm-hmm.
Yeah, so just to look at and summarize some of the comments from all of you. Social isolation seems to be a big factor, and so maybe she's coming because she's lonely and needs that social interaction. She's coming because it's free, so it's a free service. Somebody else talked about, you know, clients come to group for years because they're up and down, and we have that situation here as well, and people still get stuff out of it, whether they've quit and they're sharing with other people or they're getting additional support. Without involving the daughter, I think that efforts to assist will remain fruitless. And you're right, that's a big obstacle, and we don't really know what's going on in that dynamic. My feeling if he's identifying getting something and it's not having to see client individually, I have him attend group. Okay, so it sounds like Lita's saying that if they're not quite ready, then maybe they go into the group. Yeah. So I guess that's from a resource perspective, right?
And I would agree with that, because sometimes I do see clients who would rather hear it from other people than myself about how NRT might be helpful. I've had, you know, maybe 10 clients who, by attending group, they were able to be open to try NRT after they did their cold turkey for a while.
Yeah. And I think just to go back to what Alex said earlier on is using the agenda mapping tool. So why is she coming? What are all the things that she sees as her main issues? She may have used tobacco to get into seeing people or to start the discussion, but maybe that's not what she wants to work on. That's our agenda, right? So we're focused on how do we help this woman quit smoking. But you're right, that might not be her agenda. And, you know, we are cognizant of resources, and, you know, we can't just see clients because they're lonely necessarily. But on the other hand, and I struggle with this a lot in our own clinic, because you do have limited resources, you do have to look at those issues. But on the other hand, we talk about social support as being a really important factor of quitting smoking. So how do we help her get that support? So if we can't do it, where will she get that support? You know, these are the clients that I know for me, sometimes it's like, oh, I'm seeing that client on Monday. Darn, I don't know what to do with this client, because you do feel very, very stuck. And really putting it out to the client and saying, you know, you've been coming here for this long. You haven't made you haven't made substantial changes. What do you want to do? Like, where do you see this? What are you getting from coming here? So how do we gently put the responsibility back on the client without making her feel like you're blaming her again for not making changes, but giving her that power and saying, look, you're in the driver's seat. What are we doing here?
And I think just being very matter of fact, because you already have that rapport with that person, I think you can be very honest in your interaction. And as I, you know, think about this case, there's a lot of writing reflex there too. Like, you know, holy moly, like I got to help fix this person, but then there's that knowledge too that you can't fix anybody, but how do you be effective in that session? And that's where, you know, once again, the agenda mapping or having that conversation about, you know, these are, you know, the services I can provide here. And it's very hard, you know. So how do you sit as the clinician, you know, to have that conversation and sit in that room? It's very difficult.
This case reminds me of a client that Dr. Selby had one time. Very similar thing. Kept coming in, used the medication but wasn't quitting smoking, then stopped using the medication, just long-term use. And then, I mean, I don't remember all the details of the case, but I think one of the questions that we posed to the client was, we don't think you're ready to quit smoking, so why do you keep coming in here? And, you know, just hearing that, the client started making some changes. So sometimes they need that little, a little bit more directive approach. So MI is really important because you do want to establish that relationship. You do want to demonstrate the compassion. But at the same time, how can we be a little bit more directive in saying, hey, look, what's going on here? Because, you know, we really want to help you, but we don't feel like we are. And so maybe it's time for you to move on and get some support someplace else. And that sometimes kind of shakes people up and say, okay, this is what I want, and then maybe they're better able to articulate it. We have been meeting with her as a group, 4 of us clinicians and her. Do you think that's too much? That's a great question. What do people think? So if you have a client, and it's great, you know, the whole treatment team is there, but can it feel overwhelming for the client to have 4 healthcare providers and then just her? So I'm just curious to see what people think about that approach. Yes, too much. Ask the patient. Yep. Yes. If it was other clients involved, then no. So the clinicians are the dietitian, the psychologist, the nurse, and I guess a tobacco specialist. A lot of resources, and maybe feeding another need of hers. She seems to like it, so center of attention. So when you say center of attention, it's interesting, right? And that's what it feels like, right? So the client is coming in because they love to be the center of attention. What does that tell us, though? I think it kind of goes back to that social isolation.
Yeah.
Because she's certainly not the center of attention at home. She doesn't get a lot of attention from her daughter. And with her grandson, although he's very important to her, it sounds like the interaction is quite limited. So you're showing compassion and establishing that relationship. So I know it feels like she might be taking advantage of you, but I wonder if that's you doing a really good job in making her feel like she's got a place to go.
You know what? That's very interesting because just, before this webinar today, what Rosa just shared, sometimes you feel like, this person is coming. I know we have a good rapport, but I can't do anything. Like what? And then that's the writing reflex again, right? So for me, I feel there's a lot about, if we could do the agenda mapping, let her decide, have these questions of how, is this effective for you? What are you looking for? You've been coming this long and this is what's happening. What are your barriers? And even that, once again, she has a lot of knowledge. So you do have this knowledge. You do have these values. Like maybe it could be even looking at what is very important for the client and seeing how those values can somehow create some discrepancy with her smoking.
Yes.
Because you've kind of tried a lot of things, and I'm kind of just throwing out that now.
Yeah. And so Kim, I agree, saying something as very simple as, how can I help you today? What's important to you? So that you focus the discussion a little bit. And again, you're putting the responsibility and the power with the client. It's like, okay, you need to direct us. Tell us where do you want us to go? The other thing I'm thinking of is, I don't know what the sort of process is in your setting, and maybe you can talk to us a little bit about that, but how do people feel about telling the clients, like, we do have a limited time together, and I want to make sure that we both use it as best as possible. Not giving her the impression that you're trying to get rid of her, but also not saying, you can come here forever, and you don't have to make any changes, and this is just a place for you to vent. Because if she is looking for a place just to vent or to get that social interaction, there are other services that hopefully you can refer her to. But putting a little bit of structure or giving her a little bit of
boundaries.
Thank you.
For the session, and I agree. Yeah. And I'm sure there's a lot of people attending today's session where sometimes you have for me, I'll speak for myself, sometimes I have a hard time containing people for the half an hour, and then I got the next person coming in. So I like that idea that Rosa shared, like we've got this amount of time today in this session, what's important for you to discuss, and would it be okay if we talked about this, about smoking as well, because that's kind of like why we're there, but you also have, for me, I feel like smoking is the symptom to the root of the issue, right? And yes, there are changes in the brain. People do get addicted to nicotine, so I'm not minimizing that part at all, but I think it's, as Rosa said, to structure the session, to let them know this is how much time we have, or even when you first meet someone, as a clinician, I work this amount of time with people. If it's not working out, maybe you see another person in the clinic, or maybe your clinic decides how many times do you let someone attend. Like, is it 5 years, 10 years? Because you do have the free NRT there, so that discussion as well.
Yeah, and I mean, so I'm looking at Richard's comment, perhaps the client is afraid to quit because she will lose the social interaction she currently has. So again, and somebody else earlier on in the discussion had mentioned, rewarding this client with that work. And I kind of see the connection between the two. So, what I'm thinking is, in a way, we reward clients and they keep coming in, they make no changes, but we say, it's okay for you to keep coming in, we'll see you forever no matter what. That's good because it is, unconditional treatment, but at the same time, how do we put those boundaries in? So instead of rewarding her for continuing to not make any changes or to not come in and set goals, can we reward her when she does do that? So she might have this fear that if I do actually quit, I'm going to lose this connection. But if you kind of put it out there that she's going to lose the connection at some point, whether she quits or not, I'm not articulating it ideally, I think, because, again, I don't want you to think, well, I should let the client know, either you quit or I can't see you anymore. But it's more, for me, the conversation would go like, we've got X number of sessions together. Again, I want to make the most of this. I know that A, B, and C are important to you based on what she says. How can we make sure you have the additional support that you need? So I'm just looking. So I often refer her to social worker. Yeah.
And I like that she does extensive journaling, details of number of cigarettes and mood. So that's like a strength right there. So so you're doing all this thinking and work. You know what it's all about. So how asking the client, how do you now take that step forward? What would it take for you to do one of the interventions you stated before? Because I know Joanne, you had shared that she'll say something, oh, I could do this, but then she backpedals. Mm-hmm. And so I think, posing it back to the client, wow, you worked really hard. You had the insight. You are committed because you're doing all these things to figure it out. Now, what would it take for you to move forward? And then I think, too, with the agenda mapping and having that conversation about what you get out of the session, that might, or if there's fear that cigarette's gone and her best friend is gone, that source of comfort is gone, having conversations about all that, maybe something would happen there.
Yeah, I agree. And I'm just looking at some of the comments about, earlier on somebody said, we only have her side of the story in terms of what's going on at home. And somebody suggested a CCA referral to do a home safety assessment. And that would give us an opportunity to see what is going on in the home and maybe, get eyes on the family and the dynamics to see what really is going on, because we do only have one perspective, right? So I think that's a really good suggestion. And, I see one participant coming over and over, you're making comments about she may just not be ready. And at some point, I think you have to decide, is the conversation more about telling her, look, this doesn't seem like a good time for you to quit smoking. I am here anytime you are ready, anytime you want to pick up that conversation, and then is it time to end the interaction? Because sometimes both need a break. And that's hard for us to do.
Yes.
Because of that writing reflex.
Yes.
Because we are supposed to help people and not send them away and say, go away, come back when you're ready, because it's our job to make them ready. But you've done quite a bit with this client.
Yeah.
And it may not be the best time. That's right. Thanks, Kim. Sending away isn't necessarily not helping them. Absolutely. And remember, even with motivational interviewing, it's not that you're never directive. It's not that you're always just listening to the client and letting them lead, right? It's finding that balance. Mm-hmm. And sometimes we do have to be a little bit more directive and set those boundaries and say, I can't help you right now because whatever. And
and that's an interesting point. And that's sort of, asking permission to say, what, is it okay if I share something that I've been thinking about over the last couple sessions we had? What do you think about this? And then letting the person know. And there's an interesting thing here about, from Nicole, about personality disorders as well.
Yeah, absolutely. And then also, since Cheryl is saying something about, is there abuse from family members, right? Which, it does kind of explain some of the behaviors that we're seeing. So it's really, you're working in a very difficult situation because you don't have all the information. You don't have the whole story. And we don't with a lot of clients, right? We have to work with what they give us. But again, if you're working harder than the client is, you need to take a step back and say, okay, different approach. start with the agenda mapping. I think that's a really good place to start, to really help them. What is it that it's important? What is important to her? Because if she says to you, the most important thing is that I need that social interaction, that's great. That's a goal. Doesn't mean that you have to provide that social interaction. That's, you know, what are, asking her, what are some ways she can get that social interaction other than you?
Yeah.
And then, you know, the ball is in her court to then, to get that support elsewhere as well.
And I'm even thinking, because she's lived a long life, highlighting, you know, she's made changes in her life. She's like almost 70 years old now. So talking about, you know, what did it take for you to make changes in the past? What helped you do that? That might be helpful too. Oftentimes when I'm seeing clients, that kind of helps me sometimes, when they're very unconfident.
So I'm just looking at the time. We've got 10 minutes left, but we do want to leave some time for additional questions. People have been posting so much.
Yes.
So Joanne and Bridget, what we can do is, you know, we can summarize some of the comments, some of the suggestions that have come in, and then you can, I mean, you've tried a lot of these things already, but maybe there's some things that you can try a little bit differently. And so we can kind of help you summarize what all has been shared today. What we're hoping for from the next part 2 is if Joanne and Bridget are able to come back, we'll have to sort through that, but to follow this client and see, okay, what did you go back and do? Did it help? Where is the client at? The next webinar is the part 2 of this is in March, so it would give an extra couple of months to see if anything has changed. But let's see if there are any last questions about the case from Joanne, either yourself and your team, or from other participants. Oh, that's so nice. I'm so glad, because I feel inspired to get back on this case. I'm so glad that you feel that way.
Yes, yes.
It is a difficult case.
Very hard case.
You know, as we're talking about it, I was feeling overwhelmed and thinking, wow, this is a challenging one. So,
the head exploder.
Yes, Alex has a name for the head exploder, because you really have to think long and hard about all the different pieces of this.
And I just want to add that if anybody is on the teleconference line and would like to ask any questions, please press *1 on your phone, and that will unmute your line.
And that's interesting, Gary, what you've put here. Sometimes we need to genuinely listen, not letting the smoke get in the way. And I'm thinking, so how do you listen in that session and tolerate how that person is kind of in the same spot?
Yeah.
And listening does go a far way.
Yes, it does.
We're just going to see if there's any more questions.
Yeah. It looks like, I mean, people have been typing in frantically throughout the whole thing, so I don't know that we'll get any more.
Gary, it's really nice to see, and I think Joanne and Bridget certainly appreciate all the support today. So I'm going to just continue on, but if there are any other questions, please feel free to type them into the chat. We are going to be saving this, and if your question was not answered, we will try to get back to you. So for those of you who are interested in receiving a letter of completion for today's session, a link to the evaluation and post-learning assessment will be sent by email today by 4 o'clock Eastern Time. So as long as you have registered for this session and have attended for the full hour, you will receive that link. You will have 1 week to complete this post-learning assessment in order to receive your letter of completion. And if you attended today as a group, please make sure to email teach@camh.ca with a complete list of participants by 2 p.m. Eastern Time so we can get everyone that link out as well. As Rosa mentioned, part 2 of the Complex Client Journey will take place Wednesday, March 22nd. It'll be from 12 to 1 Eastern Time. Registration is not yet open, but we will open it next week. So look out for that, and I will be sending out an email marketing for that webinar also. Our next session for the Teach Educational Rounds will be on February 22nd on tobacco interventions for clients living with an acquired brain injury. Registration for that webinar is open on the Teach website. If you missed the beginning of today's presentation or you want to view it again and are interested in seeing previous Teach webinars, you can visit our website at www.teachproject.ca under Educational Rounds, Archive, and Self-Study. And there are a number of past webinars that you can view.
Pair that, I just wanted to, there's a comment from one of the participants that our website says April 26th for part 2. That was the old date. We are going to update that because we are going to offer it in March. So thanks for pointing that out.
Thank you.
So thank you so much, everyone, for participating. I wish you could all be in the room with me when I'm seeing a client. A lot of good suggestions there. So thank you so much.
Yeah. Thanks, everyone. Have a great week. And don't forget to text, tweet, any social interaction, social media stuff. I'm so not a social media person, but hashtag Teach Project, but also hashtag Bell Let's Talk In.
Thank you, everyone.
Thank you.
Thank you.
Bye.
Bye.